know, all of us, that we are in the middle of a COVID-19 pandemic, and very often we are looking at CT images, CT reports of this disease, and there is a lot of confusion in how to write a report, what is CORADS, how do we assess the severity on a CT report, and even on when do we need a CT or not. So in this video, I'll try to give you an overview of the current consensus that we have, and I also want you to know that this disease, the knowledge of this disease, and the basic understanding of disease is ever evolving. So I would want you to look at this video as with the time frame in perspective. Things may evolve in future, so I would want you to be in touch with us on this channel for further updates as well. But we need to know, for any information regarding COVID-19, we should know that we're dealing with an ever-evolving process where we all getting to know more about the disease day by day. So let's start with the radiological aspect here. The question number one is, when do we need to do a CT? So this is the Fleshner Society guidelines given in 7th of April 2020. It says imaging is not indicated in patients with suspected COVID-19 and mild clinical features, unless they are at risk for disease progression. That is the first thing. Number two, imaging is indicated in a patient with COVID-19 and worsening respiratory status. Number three, in resource-constrained environment, imaging is indicated for medical triage of patients with suspected COVID-19 who presents with moderate to severe clinical features and high pretest probability of the disease. Okay, so let's go further. So because of the confusion in the way the radiologists were reporting the cases, so there are societies came up with a standardized lexicon which is called as CORADS. It is a standardized reporting system which is based on the level of suspicion of COVID-19, which is graded from very low. When we say very low, it means CORADS 1, to very high, which is CORADS 5. So this is a standardized reporting system based on level of suspicion. So remember, CORADS is not based on severity, it is based on level of suspicion. It is similar to what we are all used to a standardized lexicon in radiology called as BIRADS. So it is quite similar to what we use in BIRADS, and I'll explain it to you. But before we understand, we need to understand some words like the imaging findings in this infection can be divided into typical appearance, indeterminate, atypical, or negative appearance. So let's look at them. Let us understand what this standardized terminology means. So whenever we say typical appearance, okay, typical appearance for COVID-19, what we mean is, we mean peripheral, bilateral ground glass opacities with or without consolidation or visible intralobular lines. So if you have visible intralobular lines, then you call it as crazy paving. Or multifocal ground glass opacities of rounded morphology with or without consolidation or visible crazy paving. Or third typical appearance is reversed halo sign or findings of organizing pneumonia, which you see later in the disease. These are the findings which are considered typical for this infection. Okay, other processes like influenza and organizing pneumonia as a result of drug toxicity, connective tissue disease can also cause similar appearance. Okay, that's very important to understand. And when do we say indeterminate appearance? Indeterminate appearance means multifocal diffuse perihilar or unilateral ground glass opacities without consolidation, lacking a specific distribution, which are not rounded, non-peripheral. So if you can now understand, in typical I said peripheral and rounded morphology. In atypical, in indeterminate, we are saying ground glass opacities are there, but they are not rounded, non-peripheral. And if you see very few ground glass opacities with a non-rounded, non-peripheral distribution. Okay. These findings are considered non-specific and can occur in a variety of infectious and other non-infectious processes. And when do we say atypical and negative? So in atypical means presence of isolated lobar or segmental consolidation without ground glass opacities, discrete small nodules in a centrilobular or trine bud appearance, lung cavitation, smooth interlobular septal thickening with pleural effusion. These findings are atypical or uncommonly reported for COVID-19. In these findings, we would want to consider an alternate diagnosis. And negative for pneumonia would mean that there is no CT feature suggesting pneumonia. That is the idea. And also remember, CT is not a substitute for RT-PCR. Consider testing according to local recommendations and procedures available for RT-PCR. Okay, so these are the terminologies that we are supposed to be aware of before we start looking at a CT and CORADS. Now, if I put everything into a table, typical findings for COVID-19 are multifocal ground glass opacities, peripheral basal distribution, unsharp demarcation, presence of vascular thickening, round morphology, crazy paving, combination of ground glass and consolidations, which is reversed halo where you have a central ground glass and peripheral consolidation, spiderweb appearance. While atypical findings include central peribronchrovascular apical distribution and lymphadenopathy. Very atypical findings include cavitation, calcification, train bud appearance, bronchiolitis, nodular pattern, mass and pleural thickening. Okay. So this is the background that we all need to know before we look at things like CORADS. So what is CORADS, and to understand that we also need to know these morphology would also change over time. So the CT findings of COVID-19 would evolve over time. In early stage, which is 0 to 4 days, usually you will see ground glass opacities, peripheral crazy paving and lower number of involved lobes is there. In 5 to 8 days, there is a progressive stage where there is extension of ground glass opacities and increased crazy paving pattern. 10 to 13 days is the peak stage where you find consolidation. More than 14 days, you find gradual resolution, which is the absorption stage. So the finding would also depend on the timing that you're looking at, and that will be important component of our report when we reach to the reporting level. Okay. So let's see what we have discussed so far in examples of some typical images and understand. So now you can see an axial and a coronal reconstructed CT image, and you can see in the CT there are peripheral ground glass opacities. So this is what we call as peripheral distributed ground glass opacities. Let's look at one more typical finding here. Again, this is again an example of peripheral ground glass opacities that we discussed earlier. Let's look at one more image showing us a typical finding. Now you will see along with the ground glass opacities, you also have those interlobular septal thickening. This is called as crazy paving. So you might have read about crazy paving when you were reading about pulmonary alveolar proteinosis, but we need to know that is also one of the typical findings that you may find in COVID-19 infection. And I also mentioned to you central ground glass haziness surrounded by a peripheral rim of consolidation. So this is called as the reversed halo sign, or we call it as atoll sign. This is what you might have studied in cryptogenic organizing pneumonia, and such pattern is also found in the COVID-19 progression. So these are the examples of what we have discussed so far. Now let's understand what is CORADS. Okay, so that is what a lot of people have asked me to talk about. So CORADS is dependent on the level of suspicion of COVID-19 infection. So when I say when I find the CT to be normal, or we find non-infectious abnormalities, we will say CORADS 1. Level of suspicion is nil. When you find abnormalities consistent with infections other than COVID-19, you will call it as CORADS 2. The level of suspicion is low. When you are unclear whether COVID is present, then you will say indeterminate, that is CORADS 3. Abnormalities suspicious for COVID-19 is called as CORADS 4. Typical COVID-19 is called as CORADS 5. And if the PCR is positive, you will call it as CORADS 6. So it's dependent on the level of suspicion. Let's see one by one. When we say CORADS 1 means that COVID-19 is highly unlikely. CT is either normal, or you have CT findings which are suggesting a non-infectious disease like CHF, sarcoid, histoplasma, malignancy, UIP, fibrotic NSIP. So that is where you will use the term CORADS 1. When will you use the term CORADS 2? If the level of suspicion is low and you have evidence of other infections like typical bronchiolitis, train bud appearance, thickened bronchus wall, tuberculosis. So if you notice, CORADS 1 we had either a normal thing or non-infectious diseases, and here we have infectious diseases evidence. So we call it as CORADS 2. Okay. CORADS 3 is when we want to say COVID-19 is unsure or indeterminate. Here we have CT findings indicating infection, but we are not sure if it is COVID-19. Now we have widespread bronchopneumonia, lobar pneumonia, septic emboli, ground glass opacities. So this is where we think of CORADS 3. While CORADS 4 is the suspicious finding like unilateral ground glass, multifocal consolidations without any other typical findings, and if we see findings suspicious of COVID-19 in an underlying pulmonary disease, we call it as CORADS 4. And when do we say CORADS 5? When you find those typical peripheral ground glass rounded morphology lesions, which is all called as CORADS 5. So now we have seen that this is what we call as CORADS. This is a standardized nomenclature to discuss the level of suspicion. But what about the severity of the disease? To assess the severity of the disease, we have something called as CT Severity Score. And the CT Severity Score is based on giving a scoring to each of the 5 lobes. So on the right side of the lung, you have 3 lobes. On the left, you have 2 lobes. And each lobe we give a score. If less than 5% of the lobe is involved, you give a score of 1. Between 5 to 25%, we give a score of 2. 26 to 49%, we give a score of 3. 50 to 75%, we give a score of 4. More than 75%, we give a score of 5. And then you calculate the total. So when you add up the scores, now we add up individual lobar scores and we create a sum. This range would be from 0 to 25, because each lobe we could give a maximum score of 5, and we have 5 lobes, so maximum score can be 5. Okay, so 25 will be when all 5 lobes show more than 75% involvement, that will be 25. Okay, so mostly in our standard normal reporting pattern, if the score is less than 8, you'll say CT severity is mild. Between 9 to 15, we'll say moderate. More than 15, we'll say severe. So if you notice, we went lobe by lobe, and for each lobe we gave a score. So if I again explain it to you, this lobe was like this. So less than 5%, 5 to 25%, 26 to 49, 50 to 75, more than 75%. This is how you calculate the severity score in the COVID-19 infection. Now, once you have done all this, then how will you actually frame your CT report, and how a CT report looks like in this infection is? Let me show it to you here. Now, this is how a typical CT report should look like. You should always mention the duration of the complaints, because the disease would evolve. So it's very important to look at the day. And then the CT findings should mention, are you able to see ground glass opacities, consolidation, and the distribution is the central, peripheral. Do you see crazy paving or not? Do you see reverse halo or a spider web appearance? Do you see vascular thickening, pleural fluid, or enlarged lymph nodes? So this should be in the stem of your CT report. Then you should give the CORADS. Depending on the level of suspicion of COVID-19, you will give CORADS, and you will also give the CT severity score. If there is any additional finding or comorbidity, you will mention it, and in the conclusion you will give the CORADS score and the severity of the disease. So I hope this helps you in your analysis of the CT scans that you're looking at in your day-to-day, clinical work, as well as in your exams, because we know today in any exam in the world, COVID is a very, very important topic for medical students and residents, both of them, because you're supposed to know, all aspects of this disease. And I've just tried to give you in a nutshell what should you look in the lung parenchymal findings when you are thinking about COVID infection, and what is the guidelines, and what is CORADS, and what is severity. I hope you enjoy this video. Do if you have any more doubts, feel free to ask in the comment sections, and do follow us on Damn City channel on YouTube. Thank you very much. I wish you all the best.